Karen.
You're welcome. All right, I think we'll be moving through to our professional education this morning. Navigating Rehab in Real Life. This is presented by Dr. Ann Phillips of Grit Mobility. Our bio for Dr. Ann Phillips, she's a physical therapist and clinic owner of Grit Mobility based out of Eagle, Idaho. She earned her master's degree in physical therapy in 2004 from the University of Oklahoma, and in 2020 obtained her doctorate from the University of Montana. Ann is also a board-certified neurologic clinical specialist and has worked in a variety of settings. Her work experiences include brain injury programs, acute care, inpatient rehab, home health, contract work, and outpatient neurorehabilitation. She's done this for the last 10 years, or over 10 years. These experiences have exposed her to the fractures in the healthcare system, which incited the heart behind launching Grit Mobility, capturing the people who fall through the cracks of healthcare. And I've spoken with Ann, and I know she does a lot of work in the senior community, and we're so excited to have her this morning presenting. So, Dr. Ann, please take it from here.
Hey there, good morning. Thank you guys for having me. Let me see if I can. Can you guys see this?
Yes.
Yes.
Okay. All right. So thank you so much for this opportunity to kind of share briefly on the rehab process, because it can get pretty messy. I don't know if this image is stressing anybody else out, but it could be pretty anxiety provoking. So I'm hoping to offer some helpful insights and perspective. Here are the learning objectives. I won't insult you by reading them to you, but I do want to draw your attention to this quote by Einstein. And he says, "We cannot solve our problems with the same thinking we use to create them." And I say that because we have to consider that the healthcare system is going to be addressing issues through the lens of metrics and algorithms and systems and processes and data. So going back to the quote by Einstein, "We can't solve our problems with the same thinking we use to create them." So I don't think anybody would argue that the current system is broken, and they're going to view things through a lens of algorithms and processes and data. And we're dealing with real life people. So when those two perspectives don't align, it can be pretty frustrating and pretty anxiety provoking. So I'm hoping to ease some of that. We're going to look at the rehab process a couple of different ways. This kind of describes it in a very linear fashion. However, in the real world, it is not this clean. You can jump from one level to the other. You can exit the system and re-enter it. And one of the main drivers that kind of determines what level of care you're going to be in is medical stability or medical status. And we're going to talk a little bit about that a little more in just a moment. But from a clinical perspective, our ultimate goal is always going to be to get people home, to get them back to their safe place, to their living environment, and ultimately to restore their function. In order for that to happen, a lot of times they have to receive home health services once they return home. Now, home health was never intended to be a long-term solution. Home health basically helps people kind of maneuver their home environment safely and get them to a level to where they're stable again. Ideally, they should either, once they kind of get towards the end of their episode of care, once they're able to do things and leave their home. Once they're no longer considered homebound, they discharge from home health. At that point, they should have the choice to either discharge and just kind of do their home exercise program or whatever, do things on their own and hope that they can organically return back to their baseline function. The other option would be transitioning to outpatient, and that is considered the more advanced, the most advanced level of care. So if you look at this diagram, intensive care would be the most critical level of care. Outpatient would be the most advanced level of care. And I will note too, sometimes those lines blur. So for example, we had a case to where an older gentleman was hiking, fell, broke his neck, had a spinal cord injury, and he was at a skilled nursing facility, discharged home with home health because he really needed those extra services as far as nursing and PT, OT, speech, all that. However, home health is often not equipped to handle the more complex diagnoses like spinal cord injury. I mean, I work in the neuro world, and I would say spinal cord injury is even a subspecialty. There's a lot of people that aren't comfortable working with people with spinal cord injury. So you add an aging adult with a very complex diagnosis that has a lot of potential for complications. So he needed those home health services, but they weren't comfortable working with the spinal cord injury piece. So what we did was we came in on a private pay basis, and we consulted. We helped with like the wheelchair, like getting the wheelchair set up appropriate and the bed mobility and just being another voice in the mix to help with that, with the complexities of spinal cord. So what determines the level of care a person receives? Like I mentioned earlier, medical stability is a huge driver. If they're fragile, they're likely not going to discharge home until they are more stable. Another thing within that medical stability spectrum is they have to be able to qualify to enter certain levels of care. For example, inpatient rehab, you have to be able to tolerate 3 hours of therapy to be accepted into inpatient rehab. Also, some facilities won't accept you if you have like a peg tube or a catheter or a wound. So there's a lot of things from the medical perspective that are factors. Rehab potential, that's a huge one. So if the person has a laundry list of comorbidities, that influences the rehab potential. Another thing to consider is the previous level of function. So if before they were even hospitalized, they had a ton of chronic conditions and they're an older adult, that's going to influence their rehab potential versus someone who might be younger and healthier. Another thing to consider, of course, is the aging piece with the same diagnosis. So they're going to look at a 45-year-old post-stroke a little differently than they will an 85-year-old that's post-stroke. Support system is huge. And I would even argue that support system is a big component of the rehab potential. Because if you have a strong support system, that really influences your outcome. And I love things like what Dee's doing with the life changes. I mean, she has a tremendous team. The support system and caregivers, whether it's family, friends, neighbors, those are huge drivers in the pace and the rhythm of the rehab process. because they can help kind of establish that routine and that structure that you really need after significant insults, especially when it's something like dual diagnoses, like if you have, for example, Parkinson's and a stroke, or cancer, right? So those really complex diagnoses, you really need that strong support system. And working in the neuro world, we really need help reinforcing therapeutic concepts, because in order to drive neuroplastic change, you have to offer experiences. Neuroplasticity is experience driven. If we never give someone the opportunity to experience a certain movement pattern correctly over and over, they don't learn it. Bed availability, that's self-explanatory. I won't expand on that. Obviously, if there's not a bed available, they're not going to be accepted. Informed advocacy, that's where you guys come in. I love what Learn is doing. The resources available, the networking, the case management opportunities. Case managers within the system, like the hospital system, those case managers are instrumental in where someone's going to get placed. So they're going to have some pressure from in the background as far as, like, for example, if they're in St. Luke's or St. Al's, they're going to get pressure from their administrators to try to keep them in that system, whether it's the best choice for them or not. So it's our job as advocates to offer them options, because if they don't know, they're just going to kind of go with whatever the discharge plan is. And unfortunately, funding is a huge factor in determining what level of care a person receives. Now, I want you to keep in mind too that this is not like a checklist. There's a lot of grays here, and there's a lot of dynamics in how all these factors interact with each other, because someone can be, for example, pretty stable medically, and they have a decent support system, but they have no funding. Or they may be kind of fragile medically, and they have a great support system. And they have decent funding. They may still be able to go home, even though they're fragile. So, I mean, there's a lot of ways these factors interact with each other. So what if they don't fit into any box? And we're always trying to shove people in boxes, whether it's a diagnosis label or whether it's a set. Oh. But yeah, there's in order to manage a big system, they have to operate with protocols, algorithms, and processes, right? What if people don't fit within that flow? And that's kind of where you guys come in. That's where we come in as advocates. And I want to kind of address, kind of back up as far as the whole label thing, especially with aging adults. Someone sees the number 85 as far as their age, and they already write them off half the time. So that's where we have to be a little bit stronger as far as our voicing and our presence to help advocate for options for them. I had one patient who had ALS, and she told me her interaction with her neurologist when she was diagnosed was, it doesn't really matter, you're old, you're going to die soon anyway. So I don't know if you're familiar with the diagnosis of ALS. It's a neuroprogressive degenerative.
Looks like she froze again.
Oh, shoot.
Nope, we can still hear her.
Oh, okay.
I can still hear you.
Okay, there she is.
So yeah, there's some horrific exchanges when providers are pressured by the system and they're just shuffling people in and out of their offices like cattle, which is very unfortunate. So this is a diagram. This is kind of another flow, another way to kind of look at the system in a flow, kind of a flow chart visual. I want you to consider that you can enter the system at any point. And again, this looks fairly linear, but that's not how it really works in the real world. And I want you to recognize that gaps can look a lot of different ways. It's not just services. It also references needs and those kind of invisible barriers, so to speak, that aren't always tangible, like mental health, for example. So I just wanted you guys to kind of have a visual of this is typically how it looks as people kind of flow and navigate in and out of the system, and all the gaps that are I kind of tagged like the common gaps, but you know, as you might experience the system yourself, it may look differently for your clients. I want you to also consider that there's a danger in settling with good enough, because the current system is set up just to get someone good enough. And if they're not happy, what I mean, let me give you an example. Oftentimes funding will stop once someone is medically stable. But what if they don't actually reach their previous level of function? For example, someone is discharged home, they're having to use a walker. They hate that walker, so they try not to use it. They try to transition away from it themselves, and they fall, right? So they re-enter the system. What if we can help them with that gap between using that device and not using that device safely, transition them? Insurance typically follows Medicare guidelines, even if, you know, even if they're commercial, because they're Medicare Advantage or whatever, they still have to go by Medicare guidelines for the most part. So once it's no longer medically necessary, it's really hard to justify continued services. But what if that person wants to advance their mobility to a level where it's closer to what their previous level was? If they didn't use a device before and they want to get back to that, that's an example of where our services can kind of fit in too, because we can work outside that box. And I will say the most vulnerable people are the aging population and the people who have the complex diagnoses and children. So just briefly, I just want to kind of differentiate grit from standard practices. So the standard process as far as getting therapy is it's as far as outpatient. It's clinic-based, so they have to translate what they learn within a clinic to home. And when you have someone with like a brain injury or a stroke or something like that, it's really hard for them to translate those skill sets from a clinic setting to home. Oftentimes people will say, yeah, I get it here in the clinic, but then they just can't translate it to their chair, their bed, their toilet. Another thing as far as the standard process is typically when you get therapy, based on what your physician ordered, they're going to go into a big pool of therapists, and it's kind of random. You don't know who you're going to get. It's basically whose schedule is open. And it's typically a generalist. So when you have a complex diagnosis, like someone who, again, maybe has cancer or a brain tumor or something like that, a generalist isn't always going to be able to help optimally. So this is where I kind of turn into the mom from Waterboy and accuse everybody of being the devil. But there's a difference. And I'm sure that you guys have noticed, like in the media, right? You know, United Healthcare, the shooting, and all the things, all the discussions that's happening at the Capitol as far as the healthcare system, how the food industry, all the different levels of corruption. I mean, we could talk for hours on this, but the main point is there's a lot of the chronic conditions that can be reversed, that can be prevented simply by lifestyle changes. And the aging adults are conditioned to think, especially in that really, really older generation, to trust the system. Just whatever the doctor says, they're going to do it. They're accustomed to being told what to do, and they just do it and not question it. And I would encourage you to have your clients challenge the protocols, to ask questions. And one of the main questions they could ask is, "Hey doc, would you mind looking at my medication list and see if there's anything we could take off? Are there any options? Is there anything that could be removed?" Especially someone who's seeing multiple providers. Polypharmacy is huge. People are being over-medicated, and they're having to take medications for the side effects of medications. It's ridiculous. And there's a lot of things that mimic dementia and Alzheimer's that could be reversed. Like, just real briefly, I could talk about this forever, but we know that inflammation is a huge driver behind multiple chronic conditions. And a lot of research is even moving in the direction now as far as considering Alzheimer's as diabetes 3. So, because if you think about it, if you have inflammation in your joints, in your hip, in your knee, in your shoulder, it's going to hurt. But if you have inflammation in your nervous system, it's not going to hurt. What it's going to manifest is as brain fog, memory lapses, trouble focusing, things like that. So there's a lot of conditions that kind of mimic Alzheimer's type behavior, and that can be reversed, that can be addressed through natural means. So if the provider isn't addressing sleep, stress management, food, or exercise or movement, then they're not really capturing all the bases. And this is no longer a woo-woo thing. So it used to be, mental health and well-being, that used to be kind of an alternative. Now institutions like Stanford and Harvard are really starting to recognize maybe medicine or pharmaceuticals isn't always the answer. So Dr. Naidu, Uma Naidu, is a huge voice. She's from Harvard, and she does nutritional psychiatry. She has a couple of books out, and she talks about how food can actually influence your psychology and behaviors. So not only in the aging population, but like in children and in adults and you and I. Dr. Mark Hyman is also another huge voice. He argues there's a difference between lifespan and health span. and chronological health and biological health. I mean, you could be a 40-year-old, but biologically be a 70-year-old, right? And in reverse, you could be a 70-year-old, but biologically have the cellular health of a 45-year-old. So it's important to help people recognize they can actually take ownership of their own health at any age. So how can we be part of the solution? So I did a lot of grumbling as far as the problems, but being part of the solution is basically being informed, having these conversations and networking. Like I said, I love what Learn is doing. But I think it can reach not just the aging population, but everyone in the community, because we're all linked, right? There's a lot of us Gen Xers that are taking care of older adults, and there's caregivers are burnt out, so they need help too. So, I mean, the more informed we are, the less anxiety there is. Ask questions. Really encourage your people to ask questions, to be curious, explore options. Don't accept answers that don't feel right to you. Again, within the system, they're going to go by protocols and algorithms. Those don't always fit you. Resources, advocacy, collaboration is huge, because it is not a one-size-fits-all solution for anybody. And that is it. Thank you, guys. I tried to be fast, but I think
I think you did a great job. I have a couple of questions, and please, anybody that has questions, please either put it in the chat or raise your hand so we can bring you on. I agree with I mean, personally, I've experienced a lot of this stuff myself. So this was a fantastic presentation and so enlightening in so many ways. I think that obviously it boils down to advocacy and resources, because so many people you could see get left in the cracks, and it's not just the elderly, it's uninformed and unsupported individuals. But I have a question for you too, is that who's making the ultimate decision about they're finally medically capable or medically stable enough to go back home and be on their own? Is that the physical therapist that is at the end of the treatment process before they go home? Is that the person that's doing the final analysis and diagnosis, saying, oh, they're capable, they can just move on home now and they will be okay? Is that where that link has been dropped, is really at that point, that they're going home and not being able to function properly because it hasn't been properly assessed?
That's a great question. So yes, typically in the discharge planning process, the case manager will have discussions with like the physician and the therapist, and kind of determine, again, the medical stability and rehab potential. Those, I would say, are the two main things. Support system is a part of that too. So if they have good support and they have good rehab potential and they have a good plan in place, that they'll discharge them. Let me back up a little bit. There's a lot of assumptions made too, as far as follow-up. So when someone discharges home from like a hospital stay or a SNF or whatever it might be, and they might have, say, home health, that might be ordered for a short term to help with that transition home. The assumption is they will transition from home health to the next level of care. A lot of times that doesn't happen. So either they re-enter the system, or or they adopt some pretty nasty patterns.
So
And
the case manager is really
or is
making the ultimate decision based on information they're receiving, but they're also following their own protocols in order to stay and keep their jobs and stay in line with what they're expected to do as well.
Correct.
That's
Yeah.
very
Yeah.
unfortunate.
But as a family member or as an advocate, you could come in and say, I know that this has been recommended, but I really don't want that for my mom or whatever. Like long-term acute care, for example, if you could avoid that, that's a huge, huge decision. But it takes a lot of care and support.
Yeah,
to
I just keep seeing the word advocacy, advocacy. Somebody's got to stand up for this person. Somebody's got to say something.
But if you don't know what the options are, then it's hard to advocate, right?
Well,
You don't know how the game is played.
and that's, I think, very well said, how the game is played.
Mhm.
Yeah.
And I think, Dr. Ann, one of the questions I had, it really plays into your last comment of you don't know what the options are. Like, what are the specialties in physical therapy today? You know, brain injury was one you talked about, but are 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 there other specialties that we should be thinking about around certain types of diagnoses or conditions that we should be looking for?
Yeah, yeah. So I mentioned that the most vulnerable populations are those with complex diagnoses, and then you couple that with someone who's aging, right? So so as far as specialties, there's a neurospecialty, which is what we do. There's also like oncology, so cancer rehab. So I would say cancer follow-up, cancer survivorship, that is a huge group that it's also falling through the cracks. They, once they're cancer free, the oncologist gives them a pat on the back and says, good luck. And then they're left with, well, what are the parameters, right? What can I do? What can I return to? What's normal? What's not normal? And there's some restrictions that they're not aware of, that they just have to kind of figure out on their own. So oncology or cancer rehab is another one. Cardiac, chronic conditions, let me think, pulmonary, there's pelvic health. So pelvic health is a huge growing one. It's mostly like postpartum type things, but there's a lot of people that have like bladder and bowel issues. And that's where pelvic health can really come in.
Thank you.
Yeah.
Does your website or your offer any type of additional resource information that somebody could log on to if they're looking for
So
questions to ask, options to look for?
So this QR code, if you guys scan it, it'll have my VR card to my virtual card, sorry. So you can save my information. So if you have any questions, you could always reach out and be like, hey, what are your thoughts on this? Or I have this case, I don't know what the options are for them. If I don't know the answer, I could find it for you.
Okay, that's a great resource.
Yeah, this will also lead you to my website too.
We have some comments in the chat from Katie Nelson. Thank you, Anne. You are a true advocate for rehab in our community. I appreciate your work. Donna Rogers, unfortunately, sometimes Medicare and or their insurance dictates it as far as, I guess, the follow-up. Sherry Waddell, yes, sometimes it's the hospital to get a bed open, unfortunately. Yeah, I think we all know that to be true, sadly. Does anybody else have any questions, or did I miss a hand anywhere? You can unmute yourself and pop on. Thank you. Go ahead.
Can you hear me?
Yes.
Okay. Yeah. Hey. So, my name is Ariel. I'm actually an occupational therapist, and opening an outpatient clinic, Neuro Clinic of Idaho for stroke and brain injury. So yeah, and we have chatted prior, and definitely has a lot to offer on providing information on the system. I just was thinking of like two examples that just pretty much happened to me. One was last night and one was like last week. So the hardest part with everybody is, like I said, knowing who to ask these questions to without getting a biased question. So, for instance, last week, someone found me on Google and called our office. They were in the actual hospital at this point in time. And the patient that was they were calling about, it was like the daughter, and the mom was like 102. And she's like, okay, well, she's 102, but she was walking and she was doing all these things. She is living assisted living. She's actually like a very motivated person, yada, yada, yada. But they're trying to like not let her into intensive rehab. And it's just like things like that. And kind of resources like Anne and myself can just kind of empower caregivers to um, let them know that you can continue to press the envelope on saying, this is what we want. We will take her home if we go the more intensive route. Because that's kind of what it comes down to too, how Anne was describing, if we can kind of avoid the long-term care type of options, it ends up being more of a intensive versus non-intensive option. And that's kind of the same segue. So even just people that have all this life to get back to, kind of helping segue down a more intensive route versus more these long-term facilities where it is like the generalized therapy cares. Then just in general, like Anne was saying, kind of having specialties. So even I think my goal personally is to just make neurotherapy a thing, because somehow like cardiac therapy is a thing, and like pelvic health is trending too. But like people need to know that neuro is different. And even within neuro, we don't, like me personally, I don't really treat as much like Parkinson's, ALS, MS, spinal cord injury, but stroke and brain injury. So just kind of knowing that even within a certain quadrant, making sure that you have the person that knows the most in that area is going to be the best, just because it's complicated. So many systems involved. Like for me, it is bowel and bladder, vision, brain, all of those kinds of things. So yeah, it's really great information.
Thank you for your feedback. We appreciate you jumping in there. Everybody's been very grateful. I see all the messages here. Thank you for the great presentation, Dr. Phillips. We really appreciate your time